Yeah.
That is a wonderful talk. So I'll just put the ball rolling with some questions actually regarding
Sure.
your patient selection. Yeah. And the first, do you ever try any class 1 or class 3 antiarrhythmics, or you straight away give them an option of ablation? Or if you try class 1 or class 3 antiarrhythmics, how long do you try? What drug would you prefer? And when do you offer ablation in such a scenario?
So patient selection is everything, right? So if it's a pretty new diagnosis of paroxysmal AFib and they're not very old patients with all these comorbidities, then I will offer AFib ablation up front, because that's the highest chance that ablation is going to work. But if they're 80 plus years old and have all these other issues, dialysis or something like that, then I'll try antiarrhythmic drugs. If they don't have any structural heart disease, I'll start flecainide usually, just because of the ease of starting it. I don't need to follow it with EKGs. I don't need to worry about the QT interval. If they do have structural heart disease, then I usually just go to amiodarone and see how they do with that. But I tell them, amiodarone is not a great medication to be on long term, and we just kind of see how they do with that. Usually it's for sicker patients that ablation may not be a viable option.
So even a single episode of AF in a young person, you might suggest, or do you look at number of episodes?
I guess, what do you mean by a young patient, right? If they're 30, they should never be having AFib. So it's probably one of those, genetic predisposition AFib. So you might as well do the AFib ablation on them. If they're 50, right, that's kind of that borderline age of when is it too young to have AFib, 45, 50. I will still offer AFib ablation up front, because it's either that or giving them medications long term. It's pretty rare, unless they have some clear inciting issue, like bad pancreatitis and they're in the hospital, they happen to have a little bit of AFib. Sure, I won't ablate them. But just a de novo paroxysmal AFib without any reason for why they went into AFib, they will likely have episodes again. It's very rare to just have one episode out of nowhere and then never have another episode again. But there are other reasons for AFib. Some, they were in septic shock from your UTI or something like that. Sure, that we can watch and see if they have another episode if there's some other inciting factor.
Just one more query on that. When we were doing the RF actually with, so when we used to induce the lab, we sometimes find pulmonary vein tachycardias degenerating to AFib, and they usually would be from one of the pulmonary veins. Sometimes we would just finish off doing a walk on one side actually, because that was where primarily the trigger came off from. Or sometimes we really do, we find sometimes even arteries degenerating to AFib, pathway mediated tachycardia is degenerative AFib. So with cryo, do you do an upfront EP study, do rule out all these things and take them up? Or
so if they have the diagnosis of AFib, I'll do PVI all four veins first, because I guess there's data showing they used to do that. Just find the main trigger vein, just isolate that, but they found that a lot of times they would still have AFib. You go back, another vein is active now. So at least in the US and I think in Europe, it's pretty standard. You just isolate all four veins up front. Now, whether to do an EP study after that is about 50% of people do, 50% of people don't. I personally do, because if I find, there's a pathway or something like that, I want to get rid of it at the same time. Or if I induce atrial flutter, I'll go ahead and do it. Some people avoid that because they say that, they have to take out another ablation catheter to do that. So it increases the cost of the procedure. They would rather have the patient declare themselves as, okay, they're going to have AFib now, and then bring them back for a second ablation. So I've seen people go both ways with that. I prefer to try to get rid of everything at one stop if possible. But, it's controversial, I guess, because it's not an accepted decision on how to go about that.
Regarding the procedural aspects, do you do a CT prior to your CT to plan your procedure? And have you ever used the 23 mm balloon, or you always go with 28? Have you ever used a 23?
Yes. So 99% of the time, 28 millimeter balloon is what we use. but I have used the 23, and the CT scan is what helps make that decision. I do try to get a CT scan before every case if possible. It's nice to know the anatomy going in, especially if it's a left common or if there's three right-sided veins or something unusual that might pop up. I'll go to the 23 millimeter balloon if all the veins that they measure out are all under 15 millimeters in size and diameter. I'll consider using it, but a lot of times even that they'll undersize it on the way they measure it on the CT. So my still go-to is 28 millimeter for 99% of the cases.
One more question, actually. Post-procedure, what is your regimen of antiarrhythmics and anticoagulants? You said you give anticoagulants for 6 months and you give antiarrhythmics for the initial blanking of 3 months. So what antiarrhythmic even in a low CHAD score, how long anticoagulation?
So during the healing phase, right, the blanking period after the ablation, you get some swelling in the tissue. They say it takes 1 to 2 months for that swelling to go back to normal. Just to prevent arrhythmias during that blanking period, I'll put people on flecainide with no structural heart disease, otherwise amiodarone if they do have cardiomyopathy or MI history.
And even in a low CHAD score, you give anticoagulants for 6 months?
Yeah, unless they fight back. So if people are, there's risk of 0, then maybe I'll stop it after a month. But usually I like to keep it on because if they develop atrial flutter, atypical atrial flutter we sometimes see after cryo, I can bring them right back to the lab without doing a TE and just do a touch-up ablation to get rid of the flutter and be done with it.
Thank you.
Yep.
Right now, I think recently only we got a cryo in India. I think hardly a month. So, what do you think? Availability of cryo changes your practice. How much it changes? Make it more aggressive, or as an alternative to drug therapy? Because most of the guidelines now equating cryoablation with drugs as a first line of therapy. So, in your experience, what do you feel like? A country like India, where we have just started, how do you think that this will progress for a period of time?
So, just to give my background, we started doing cryo maybe 8 years ago, and before that, it was all RF. And with RF, I probably did something like 30 to 50 AFib ablations a year. And it was difficult because sometimes it was difficult to isolate the veins or some other issues with RF, the technology itself. With cryo, every single case, as far as the ablation portion of it, will take 35 minutes of actual ablating in the left atrium. I can schedule my whole day much easier knowing that this AFib ablation will take 2 hours or less, and I can schedule other procedures around it. So there are days when I can do 3 or 4 AFib ablations in a day and be done by 5 p.m. without any problem. So that is the huge way of how it's affected my practice. And plus, I feel like the way we're doing it, it's much safer. I'm not worried about pulmonary vein isolation, atrioesophageal fistulas, perforation. When you have a balloon-shaped catheter, it's almost impossible to perforate through the tissue because it's the diffuse area of pressure that you're placing. So the procedure is much faster, in my opinion. It's safer. If I ever go in to do a redo ablation after cryo, those veins, for the most part, are still completely isolated. So it's very rare to get reconnection after a cryo ablation. Because of that, now I do about 250 to 300 AFib ablations a year because it's almost the easiest procedure we do and the most reproducible procedure we do. So it does make a big difference in how we approach the AFib patient, right? Normally you'd see an AFib patient, you might say, okay, ablation is the last resort if all else fails. Now here we have a pretty easy to do therapy that we can offer earlier and not scare the patient away saying, all these risks associated with it. It's pretty easy to do. So it does take a certain number of cases to do before you feel comfortable. Probably 10, 20 cases, and you feel like you could ablate everybody with AFib. Just bring them in and get it done. But the patient selection thing does help increase your success rate.
Questions from the panelists?
No more questions. I think we can close the session.
Okay. Thank you very much.
Yeah.
Thank you.
Thank you. It was nice. It was nice to listen to you. It almost becomes like cryo is, as you said, a very easy procedure, and the uptake, your uptake has almost become 5 times your earlier volumes. Actually, what's good.
Yeah.
That's nice to know. Thank you. Thank you.
மூந்தன் இருக்கீங்களா?